I'm Courtney Evans, and I work as a clinician here on the mobile crisis team, and I have been a clinician for about 15 months now. We are dispatched through the Fairbanks Emergency Communication Center here in Fairbanks. We like to be there in 20 minutes or less, and we serve the entire Fairbanks North Star Borough. So we serve all the way down to Saltra, up Elliott Highway to Chena Hot Springs, and then, as far towards Denali and Healy as the borough goes. Uh, we will respond in person as long as the scene is safe, and that is where the Fairbanks Emergency Communication Center comes in with our dispatchers. They assess for safety. They figure out if police is needed, if an ambulance is needed, or can the mobile crisis team go in independently. We are a team in Alaska that doesn't need to co-respond. We are equipped and able to go to scenes by ourselves. And so we will go in person. However, there are situations and circumstances where someone might only want us to respond via phone, or the scene is unsafe. Maybe they have a weapon or there's a presence of a weapon in the home. And in those cases, we'll respond via phone. We assess for safety. And if an in-person response is warranted after that, we may go in person. But a lot of times we usually are able to resolve it, via the phone and get things sort of sorted out that way. And so we do both.
Hi, my name is Giles Hawthorne. I am on the Fairbanks Mobile Crisis Team here in Alaska Behavioral Health.
We do work in teams of two, and so each shift has a master's level clinician and a peer support specialist. And so the peer support specialists, they really come from that holistic, experience driven approach.
The clinician and the peer are alerted through an app. We also have a fail-safe too. I have the clinician call the peer too. We read the notes on the app, depending on the level call. Sometimes it could be over the phone, sometimes it's in person. It's 90% in person. We meet on scene, and then it's a peer-led interaction with the assistance of the clinician, and we assess the situation, kind of almost like a kind of an intake in the field. All right, we figure out what it is, what do they need. We need to know the problem. We need to know what it is that we can do. Once we've come to some type of resolution, whether it's a resources that they've been given, or if it's a taken to perhaps the homeless shelter or wherever it is, that's when we'll say, okay, so in summary, we did this for you. I'm going to check in with you tomorrow or whenever you want to follow up. And so that's kind of the whole kit and caboodle of the call. Within the call itself is a lot of talking, a lot of interaction, talking to them in the car, sitting down on the curb with them to see getting down on their level physically to see how they are doing. And that's how you build rapport, is for someone to actually show that they care. And by doing that is taking the time out of your day and talking to them and sitting down on the grass with them.
And then where the master's level clinician comes in is we typically do a lot of the de-escalation techniques. We're assessing for risk, we're assessing for suicide, homicide, gravely disabled, things of that nature. And so we're able to really collaboratively work together to meet the patient on all different sides of the spectrum, to make sure that they get adequate and appropriate resources and access to resources. And then our peer support specialist typically does all the follow-ups. And so that's what also makes our team very unique, is that we do follow-ups for up to 2 weeks. The first one happens within 24 hours. Second one happens in 7 days. Third one happens 2 weeks after that initial call. And there can be more in that time. There could be less, but that is the ability or the time frame where the peer support specialist could help them fill out a Medicaid application. They can get them a Lifeline GCI phone. They could get them into Alaska Behavioral Health for a psychiatric appointment or a walk-in counseling appointment. They can get them connected to housing resources. Really, the sky's the limit on what our peer support specialists can do in those follow-ups. And that's where we bridge the gap of resources, rather than someone maybe slipping through the cracks or continuing to participate in this cycle of services. We're able to really do that upstream prevention approach, get them into some services and get them stabilized and able to really reach the goals that they want. The calling 911 is to really just assess for safety. We trust our dispatchers at the Fairbanks Emergency Communication Center. Like, we trust them with our lives, basically. You know, they're the ones making the decision of whether they're going to send us in alone or whether we need police, or they're going to send police when we request them. And they take that very seriously, and we trust them with that decision making. And so, you know, they're trained in it. They have protocols. They're nationally renowned center, and so we trust in them to assess our safety, which is something we're not trained in. And so we try to tell people that, you know, that 911 is really just there to better understand what you're needing so that they can provide the appropriate resource, you know, whoever that may be. And that really, even sometimes though, if there are no other factors and you really just want to talk to MCT, they've gotten to know too that, you know, they can just put people right. They have to run through certain protocols, but it's pretty fast to get them connected to us for the mobile crisis team. And so we just try to be very mindful that calling 911 is very scary. It's usually not something you're doing unless you're having the worst day of your life. And so that's where we encourage the non-emergency line, and also that, you know, really it's just for our safety and their safety, and our dispatchers do a wonderful job and they want to make sure everybody gets to go home at night. And while it's scary, we are more than happy to talk to you, and we're always here.